Freeze is a common response to those who are in chronic threat situations and who feel unable to protect themselves, such as a child who is abused in the home. When someone freezes, their body is trying to protect them and has decided it is the best tactic to survive a threat.
There are a lot of reasons why we get stuck. I came in, and this was when I was doing mind-body work in the 60s. He came in and he was having real jaw problems. His jaw was just rigid. He had TMJ. So I was working with those muscles, helping him to relax the jaw muscles. And then all of a sudden this image came up. He had wanted to be promoted in his job. And it looked like this other person was kind of making nice with the boss. And so he felt like he wanted to kill this guy, fight. But you couldn't do that, of course. Obviously, he had to stuff it, but his jaw had it. So as he released his jaw, that's when the whole image and his perceived threat from another person, just about a job promotion, but it was perceived threat. You know, socially it would be inappropriate. It would have caused him all kinds of problems. So he needed to suppress that anger, and you suppress it with the muscles. This is what Wilhelm Reich talked about, armoring. So you have this unacceptable feeling, so you armor against that feeling. In this case, it was in his jaw. And actually the way it came out, he had this image actually of biting this guy. I mean, how primal can you get? That he was really, he just was so upset that that this other person got promoted and that he didn't. And so while he's talking, I see his jaw starting to stiffen. I see his shoulders starting to come up. And then I might say, I'm just wondering if you're noticing what's happening in your jaw or your shoulders just while you're talking about this. We can talk about it. Let's just put the talk about it, just put it to the side for a few moments, and you can come back to it anytime you want. But just see what you're noticing right now in your jaw. Then I might have them do some kind of movements, like just opening the jaw till you feel an increase in the resistance and the tension, then letting the jaw close a little bit, then letting it open a little bit more, and then letting it close. And then again, every time there's a release of activation, a release of energy, just encourage the client. So just noticing those sensations. Maybe they report tingling. Just notice the tingling. Notice if it increases, if it decreases, or if it changes, if it stays the same, or if it changes to something else. So again, it's working with the energy, the activation that's got locked in to those frozen muscles.
The basic physiology of trauma in his book.
Waking the Titan.
Yes.
Yeah.
And then I dived into the PTSD literature. I started to read. I started out with a lot of articles by Bessel van der Kolk, who was well-known, had evolved some of the early seminal concepts of trauma with dissociation, with the involvement of the body, and the body keeps the score.
In his book or article?
That's an article.
That's an article. Yeah. The body keeps the score. Yeah.
Yes.
Trauma is an injury, is a wound. Something happens to you that is too big for your mind to comprehend. It's overwhelming by definition. It's too much. And so the consequence of that is that you get stuck. And things keep coming back and you get overwhelmed again. And your mind and your brain and your being is incapable of comprehending and making sense out of that event. And because you cannot integrate it, it keeps coming back. something that may be traumatic for me may not be traumatic for you. But the sort of traumas I see, I'd be very surprised if people wouldn't get blown away by it. If you're responsible for going through a red light that causes a car to plow into you and to kill your kid, I think most people would have a hard time with that. So the notion that, oh, it's only vulnerable people who get that is a little bit of naive thing. When traumatized people start trying to become mindful, they run into a minefield inside because all that trauma sits inside of you. And as you get to know yourself, you get to see how much you hate yourself, you know yourself, you can't stand what you have done or how weak you are. And so it becomes very painful. So that gets in the way of resolution.
When I read that, I realized that there was a physiological disruption in PTSD, which would result in destabilization of the body and brain, and specifically the autonomic nervous system. And that this might explain all of the visceral, the gut, the heart symptoms, when the event was traumatic enough to result in a fight-flight response, which is a sympathetic part of the autonomic nervous system.
Okay.
And then, because the patient was helpless, to result in a freeze response, which of course Peter writes about extensively and is the basis for a lot of his theories.
Exactly.
And I borrowed from that with regards to the importance of the freeze response. Mm-hmm. Because in the freeze response, and this is Peter's work, this is all of his conceptualization.
Which has been very helpful to the field in general. I mean, we're all kind of standing on high shoulders that he set out for us.
Exactly.
Yeah.
Our arousal level. And so we're just taking a walk, and our energy is, basically moving like this, up and down. If we're taking a run, there's more movement in our energy. If somebody's chasing us and threatening us, then our energy is really excited. Now, what happens in trauma is that we have this tremendous excitation, and then, boom, we're overwhelmed. This energy becomes locked. It becomes stuck in our bodies and our nervous systems. When this arousal, this activation, this hyperarousal doesn't get released, it leads to all kinds of symptoms, not only the classic symptoms of PTSD, like flashbacks and nightmares, which Ray experiences, the physical symptoms, chronic pain, chronic stiffness in different parts of the body. First, we have to recognize that trauma has emotional effects, it has a cognitive effects, but primarily it's a physiological process. And until we begin to resolve it at the physiological level, it's not possible to resolve the emotional and the meaning issues that that traumatized people have. When a person is deeply traumatized, the ability to read others' emotions by their faces and their postures is very much compromised, so that they're really not able to take into that the empathy. And often clients even feel like they've done something wrong because they're not able to take in that soothing, to take in the kindness of the therapist. And then equally, the therapist is often very frustrated because they don't know why what they're doing isn't working.
Animals who are free, like an opossum or a gazelle on the Kalahari plain, run to the ground by a cheetah who freezes because they're helpless. If they're not killed, they'll come out of the freeze, and they'll come out of it with a shaking. They'll tremble and shake like a seizure.
Exactly.
And there's a famous polar bear video that I use in every lecture that shows a bear who's been anesthetized for tagging and who comes out of it and goes through what looks like a grand mal seizure.
An animal like that, he's just still blinking there on this little. Oh, that's all right. He's just perfect. He's absolutely perfect. See the size of getting a bit bigger neck and so on. Yeah. So. Holy snapper! He's about as big framed as you'll probably get. watch that animal after he finishes convulsing, you'll see, because he's aware of the fact that we're all around him, and it's a very stressful experience for an animal like a polar bear. After he settles down, and then he'll start doing a couple of deep breaths, and then he'll breathe really nicely, and it'll really... Now go, here he goes. See how he's breathing in now? You can see, so that even though it looks a little unpleasant to look at him convulsing like that, in fact, it lets off all that stress, and he then is able to relax and sleep the thing off.
But in point of fact, and this is a National Geographic film, and the people observing it don't talk about the fact that the act that the animal is coming out of, is creating when he's coming out of this freeze, is a replication of what he was doing before.
This polar bear is running, it's in the stress response, it's getting away from these scientists, I guess, who are doing this tagging.
Yes.
Goes into this anesthetized freeze state, this immobility state, and then on the other side of that is in this kind of stereotypical grand mal seizure kind of moment.
Right.
And in that, you're suggesting that the movements that the bear is making, that looks to us like a seizure, is actually, it's complete, I'm now putting a word there, completion of what it was doing before the sedation.
Exactly. It's completing the act of escape. In other words, it is extinguishing all of those procedural memories that, if it hadn't done that, would be stored in unconscious memory because it's a survival tool as far as the brain's concerned. It would be stored there as a false message to be replicated every time that the person experienced something that was like the event that had caused the animal to freeze. So it is completing in its memory, procedural memory, the act of escape, in essence.
And by doing so, in some way extinguishing the feeling of threat.
All the body sensations associated with that event are now extinguished because it's like ringing the bell without feeding the animal.
Okay, it's like ringing the bell without feeding the animal.
In other words,
you're referring to Pavlov, I guess.
Exactly, because it is classical conditioning. That's how we learn to survive. All of Pavlov's tools that he used to condition animals with were survival tools.
Food
and pain, mainly.
Food and pain. Those are two very compelling survival tools.
Survival tools. It's a continuum. I call it the cultural cage.
You did. You called it the cultural cage. Yeah.
Because animals who live in cages die young. They have a very poor survival rate.
They show the same autonomic dysregulation diseases, I suppose.
They're helpless. Whatever happens to them, they're helpless. And the helplessness is reinforced many, many times a day. And as a result, they never discharge whatever trauma they experience in the course of being a resident of a zoo or whatever situation there is. Pavlov's dogs were all traumatized. They lived in cages and they were exposed to pain.
I guess that's one argument against studying animals in captivity as like ideal subjects for human. Yeah.
It's a real problem because you've created the neurochemistry and the physiology of trauma.
Yeah. So you're going to be changing the look of the bell curve.
Right.
Yeah.
Right.
The cultural cage.
That's what classical conditioning. It's how we learn how to survive. We learn how to perform acts with procedural memory for skills. We learn how to survive procedural memory for traumatic events. And we acquire this information that suggests certain things are threatening to us by conditioned responses.
And when these responses are elicited by a traumatic stressor, something that's threatening, that instigates the fight-flight response, or even, if necessary, the freeze response. If that process of fighting and fleeing and even freezing is able to complete, you're suggesting that you can stand up and kind of walk away from the event to some extent almost as if the thing didn't happen, or at least it didn't happen and keep you stuck there inside it, the feeling of it continuing to happen?
Exactly. This is a phenomenon of the present moment and the past.
The present moment and the past.
In the present moment, we are moving along through life, acquiring new information, planning, expressing intention. In trauma, when a person has these unconscious procedural memories still there, they're perceived, if there's a cue, as being in the present moment. And so they keep interrupting that process of moving on consciously in life. And so we progressively become stuck in the past, in trauma.
We're now aware both of these dynamics, but then also aware, I think both you and me personally as well, that this isn't a forever kind of thing. That it's real. We're talking, like, when we talk about the vet coming home and not being able to choose between the cereal boxes and such, we're talking about a real struggle that he's having, like a very real, almost physicalist struggle. Like, in the brain, signals are going off that says things different than pay attention to this moment. So people who are suffering with these kind of conditions, and we're kind of layering that into a spectrum where it could be a little bit or a lot, right? This request of the nervous system to take you out of the present tense and reinforce this traumatic recapitulation, this traumatic reenactment. Okay. That's a very real thing. You could probably, in fact, I know you could, if we took more time to do it, track down what's happening precisely in the brain.
Sure.
So that it's no longer, if we just say it's in your head, it's all in your head, that's just in your head. It is, in a way, in the fact that the brain is in the head. But it's not like just something that we're making up.
No, it's the brain working.
It's the brain working, just working in this particular fashion, which provides this signal of distress happening. And at the same time, now we realize that that doesn't have to continue. That a person with that kind of context in that situation, at least some mitigation of those procedural memory cues can be extinguished, can be minimized, can be... And a lot of your research has been based on kind of like what makes up successful therapy for these kind of conditions.
Yeah. As with everything else, I'm on the extreme of the field because I don't approach it from a psychological standpoint. I actually tell people in the lecture, I don't use the term psychology or psychological. It's a metaphor. It's a metaphor for the mammalian emotional brain, the limbic system. And that's all it is. It is all brain function. So something that is psychological is neurophysiological as well. And it doesn't help to give it the names that psychology does to the diagnosis unless you look at what the process is within that part of the brain that's creating that.
Which could be tracked, I mean, or at least with the advancements in tracking medicine, functional MRIs and everything, you can watch what's happening in the brain.
Now with these incredible imaging studies, especially functional MRIs, fMRIs, you can see where the blood is going, to what area of the brain, with a certain thought function. Imagining something, it'll go to a certain area. Seeing something, it'll go to a certain area. Reading something, it'll go to a certain area. Depending on the content of that sensory experience, that will result in a certain part of the brain lighting up, and we can now define those parts of the brain that control specific emotional states and wealth states by these kinds of techniques.
And when you look at that, do you think, oh, this is what's happening in the traumatized brain, and that's the best a person can do with that is learn to manage the symptoms?
Well, we can look, it depends on how you approach this.
Okay.
There's some people in the field of psychiatry who are doing these kinds of scans and then prescribing drugs based on what happens when a patient has an emotional response. And that's very controversial. But what we can do is to determine what parts of the brain are operative. And what is the system of message transfer within the brain when a person is in fear, fight and flight, in terror, is becoming helpless, and in the freeze state. We can see what parts of the brain are operating that seem to create these states. And then we can devise, well, what can we do to affect those parts of the brain selectively? In terms of drug interventions, but that's a sticky wicket. Because when you put a drug in the brain, The brain has an equal and opposite response.
It's got to do something else.
It adapts to it, and some other change takes place to try to balance the effect of that input. And that happens with medications. If you give a shot of insulin, the body responds in a way. If you give thyroid hormone, the thyroid gland eventually will atrophy because it is not needed anymore.
Right.
So the body always responds with an equal and opposite reaction to any input of a foreign substance.
So targeting these specific brain patterns, processes with drugs is, like you say, a sticky wicket. It's like a good way to get into other trouble.
Yeah. And it's also like trying to kill an ant with an elephant gun. I mean, you're trying to find a precise thing, and you're blasting your brain with this huge amount of neurotransmitter mimicking substance. And you never know really what the response is going to be throughout the brain.
What would be a better, I mean, of course, being trained as a therapist with somatic experiencing, like I have my understanding of it, and then but I've watched you, and you've been kind of tracking into what seems to be your opinion on what are the necessary and sufficient conditions for kind of taking out that ant, if we're going to stick with that metaphor, like in a more precise way.
That's exactly right.
Yeah.
And the ideas are based on what parts of the brain operate in a traumatic experience. What parts of the brain operate in a threat? And of course we know that this little one neuronal center called the amygdala.
The smoke detector.
It's the smoke detector, it's the alarm system, it is the critical element in the brain for processing a threat. You need it to survive, but if the event is false, or if you actually go into fight, flight, and then freeze and don't come out of it, then that little area is not doing you a favor. Mm-hmm. It's created the arousal state that then can lead to being traumatized, depending on whether you go through the freeze discharge that will clear procedural memory for it.
Right.
And probably it's also the area that stores some of the procedural memory for a traumatic event. But it is the early warning system. And if you can shut that down,
if you can we're going to have a visit. Inhibit it.
If you can inhibit the amygdala, in other words, shut it down or shut it off. During that period of time, if you then access a procedural or a declarative memory for a traumatic event, there won't be any arousal. And the hooker behind the self-perpetuating nature of trauma is that even memories triggered by internal cues set off the amygdala.
So that just in internal state changes, yes, feeling changes could set off the amygdala to make you feel like some life-threatening event is happening, even though nothing is actually happening.
Yeah. Like a cramp in your stomach, or like a flip-flop in your heart. In these cases of these psychosomatic diseases, the symptom of the disease may trigger the amygdala and make the symptom worse.
Like the smoke alarm goes off, and then you go into this reaction that then starts to make the heart palpitation worse, and it kind of feeds on itself.
Exactly. And it's called kindling or neurosensitization, and it's ubiquitous in trauma victims. They all have this hypersensitivity to any kind of cue that will set off the amygdala.
Kindling in the sense of like making a fire, you have very small material that catches the flame much faster and then perpetuates like an accelerant.
Right. It burns abnormally fast and starts abnormally easily. And that's what the amygdala does in trauma. It is kindled. And it's kindled to all these little cues that are in procedural memory.
So if you can access those procedural memory cues while the amygdala is attenuated down.
Right. That cue will come up and there'll be no arousal. And it's like ringing the bell with no food. And that little memory will be there and it will float to the surface and pop just like effervescence because it didn't trigger the amygdala and therefore it's extinguished. That little piece.
And what would that look like you've witnessed this, I witness this all the time in my practice, but what have you seen of this in your, what does that look like for people? How would you describe that in terms of what that looks like?
If one does this in the context specifically of a somatically based trauma therapy session, in other words,
by somatically based, what do you mean by somatically based?
That enlists the body sensations,
Okay.
the body feelings, in the process of extinguishing the traumatic memories. And it's a fine dance that one does to do this. There are many approaches to it, but it's a fine dance to bring up those memories in the body in a state where the person is not going to arouse, because what you've done has shut down the amygdala or inhibited it. And if you achieve that, then during that state, you can bring up all sorts of stuff. Now, it's best to do it little piece at a time and extinguish little bits at a time, because if you get enough of it, it's going to overcome your whatever skill you are exercising and inhibiting it. So you have to do it piecemeal.
Almost like replaying things that happened.
Exactly.
And you mean that in a very literal sense, like the brain actually like saying to you, that thing is still happening.
Exactly.
Okay, Bob, you've got there this kind of sense of like that there's this completion possible, and then we're kind of noting that there is some way that you can end up maintaining or kind of accumulating those procedural memory instructions.
Yes.
What would be the difference? Like, why would one person or the polar bear or some animal or some human, why would one complete and another would have that completion disrupted to where they were maintaining these survival instincts or survival cues?
And that's the core of trauma.
That's the core of trauma. That question right there is the core. Okay.
Which is how resilient they are. And what creates resiliency? What creates resiliency is predominantly the way you experience life in your earliest childhood. Because each time that you freeze and don't come out of it, the burden of trauma goes up and up and up. And so once you've been traumatized, you'll be more likely to be traumatized again. And after you're traumatized again, you're even more likely to be traumatized again. And that because you tend to freeze more readily. So the infant who dissociates or freezes, and dissociation is what you experience when you freeze. They are the same. When the child dissociates because they get fondled, or they get smacked, or they get hit, or even if they never have a chance to become attuned to their mother, which is integral to developing a sense of self, who you are, under those circumstances you are more likely to be traumatized. And so you are traumatized again and again. And when I discovered, and that's in the literature as well.
That's out there.
Yeah, and when I read that, I started to take histories on all my whiplash victims.
What'd you find?
And all my chronic pain patients. They all had traumatic childhoods. All of them. Many were incest victims, these women. Many were physically abused. All of them had terribly dysfunctional, stressful family lives, most of which were demeaning to them. They were not valued. And so they never developed this sense of safety and of self-sufficiency. And they always, therefore, tended to be helpless.
You said that trauma is the response, like the incompletion in the face of helplessness. Is it?
Trauma is a negative life
experience,
which can be life-threatening, and it usually is, in the face of helplessness.
In the face of helplessness.
That combination, life threat and helplessness, is what constitutes trauma. But there's a shade of meaning there, which has a huge application to what this is.
Wow, that would be an interesting shade to kind of shine some light on.
Well, the meaning of the event may be trivial to one person and overwhelming to another based on their past experience.
Exactly. And that past experience, what you're suggesting in terms of resiliency, is either kind of compelling one person toward greater sense of helplessness or another person toward a greater sense of agency.
Yes, exactly. Exactly. Which, of course, that led to the second book, which is the trauma spectrum, because if that's the case, then trauma is a bell curve, and their trauma may be relatively trivial.
But you could still.
But if you're helpless, and in trauma, you're in this state involuntarily, not respective of your need at the moment. You're in this state of fight-flight when your brain tells you there's a threat even though there isn't one. And then you collapse in a freeze response even though it's not useful for digesting. So the extremes of this are pathologic states, especially when they're not associated with other factors in the body that would prompt you to go into those states. They need to be finely tuned to the needs of the body, and in trauma they are operate irrespective of these needs, based only on internal procedural memory cues that are false.
Presumably, what you're suggesting, or what I think what the whole field is suggesting with that, if you get this inappropriate signaling or processing happening, you're going to see symptoms that don't make any sense in the classic medical profession, where there has to be a point A to point B reason for something to be happening.
That's the dilemma of physician, of the allopathic model of disease as a fixed state that we can measure. Because this is not a fixed state. It is by definition a very unstable, oscillating state. And there is no lab test that is definitive, because the lab tests are constantly changing. If you take a person and do a series of lab tests over a 3-hour period, and they'll be all over the board, which makes no sense to the allopathic model of disease.
What would they then say? It's all in your head?
Well, they would say, well, that's just normal variation. It doesn't make any sense. And besides, the lab tests aren't far out of norm. They're the extremes of normal. And of course, normal is determined by the bell curve.
Right. So if so many people are getting involved in this, then
this is one of the dilemmas of medicine in general. And there are a host of these conditions.
I mean, potentially even migraines and chronic fatigue, fibromyalgia.
Yes.
Yeah.
All of these strange diseases that don't have a fixed state that you can measure.
And that medical doctors kind of put in the syndrome X category sometimes, or just like throw up their hands, I don't know what to do.
Yeah. Fibromyalgia is kind of the prototype disease for that, because all the other diseases commonly occur in fibromyalgia. Fibromyalgia is a disease mainly of widespread pain. And then, of course, if you look at the TV ads now, there's a drug now that they've got for treating widespread chronic pain or fibromyalgia. It's a very hard to pin down syndrome. It has many of the other components of the diseases we just talked about. It often follows a traumatic event, but not always. And there is an increased incidence of childhood trauma in it, but not dramatically so, and not everybody with fibromyalgia has demonstrable childhood trauma. So there's a lot of speculation in the field. I personally feel that it may well represent early pre-verbal trauma, birth trauma, even perhaps pre-birth trauma, which, if you believe in what I'm saying, you realize it exists, because procedural memory pathways are present in the fetus.
What you just did there takes it one step further again from, I think, the normal cultural understanding of trauma, which is like, oh, something bad happens to you, you remember it, you can't stop thinking about it, you're traumatized. But going back again to the role procedural memory and the autonomic nervous system and stress response plays, saying that if the pathways are available for the fetus for procedural memory cues to be working, then if they're going to elicit this response but not settle afterwards, not complete per se, then they're going to end up kind of holding on to that instruction of survival, that survival response.
I think this is speculative material, obviously.
Okay.
But we do know that infants feel pain. They didn't used to think they did before the age of 18 months or 12 months. But they do. And we know that if you stick a needle in a fetus, in the uterus, to test for blood type or to test for substances that might suggest a birth defect, that the cortisol goes up The fetus responds with a startle response, and the cortisol stays up for a long time, longer than an infant and longer than an adult by far. So the cortisol is a hormone that is triggered by the fight-flight response and by pain.
So intimately tied with the experience of survival and fear response.
And with threat.
With threat response.
Pain.
Yeah.
So the fetus can feel pain, and pain by itself is a traumatic event.
So the trauma spectrum then is kind of this lifelong accumulation of either successes or incompletions of these kind of responses. And where you end up on it starts as early as the in utero experience. Like where you end up in terms of your dominant position on the trauma spectrum, either very distressed, very easy to excitement or agitation, or very at ease and willing to accept life's challenges and move through, resilient.